I'm Morgan, and this week I was assigned Cushing syndrome. The case introduction, MK is a 35-year-old, relatively healthy Caucasian female. She is married with 2 teenage children. She presents to her primary care provider with complaints of a dull but persistent headache, significant weight gain over the past 6 weeks, significant facial hair growth, menstrual abnormalities, excessive thirst and appetite, a depressed mood, and anhedonia, or a decrease in interest of things that she used to like doing. Her family history includes a brother that was diagnosed with type 1 diabetes at age 11 and has been recently evaluated for high blood pressure. Her father is a cancer survivor of childhood leukemia, and her mother has rheumatoid arthritis and breast cancer. MK does not smoke, and she occasionally consumes alcohol. She has allergies, including ragweed and dander, and she does not take any prescription medications. She does take a multivitamin daily and ibuprofen as needed for the occasional headache. And she presents today at her PCP. Cushing disease is caused by the hypersecretion of cortisol. The endocrine glands secrete excessive amounts of androgens or estrogens. Cushing disease alongside excessive cortisol can manifest with excessive levels of aldosterone. There are 2 types of Cushing syndrome: ACTH-dependent hypercortisolism and ACTH-independent hypercortisolism. ACTH-dependent hypercortisolism occurs because of an overproduction of ACTH by the pituitary glands, while ACTH-independent hypercortisolism results from a benign or cancerous tumor of the adrenal glands. Cushing syndrome can manifest as virilization or male characteristics such as increased body or facial hair growth, a deepened voice, and an enlarged clitoris. Cushing syndrome can also cause sterility or the inability to conceive and maintain a pregnancy. Cushing disease typically manifests with excessive weight gain of adipose tissue, particularly in the midsection. This is known as truncal obesity. These people may have increased facial weight gain, which is manifested as moon face, or deposits of adipose tissue in the cervical area of the vertebrae, or buffalo hump. Epidemiology: about 2.4 million new cases occur annually. Diagnosis is usually about 3 to 6 years after symptom onset. Hypertension and glucose metabolism abnormalities are usually precipitating factors for these people, and the mortality rate is around 10 to 11%. The pathophysiology of Cushing disease: in ACTH-dependent hypercortisolism, excess ACTH stimulates an excess production of cortisol. There is a loss of feedback control of ACTH, and the cortisol-releasing hormone is inhibited. In ACTH-independent hypercortisolism, benign or malignant tumors of the adrenal cortex oversecrete cortisol. The increased levels of cortisol suppress cortisol-releasing hormone and ACTH. In Cushing disease, increased production of ACTH causes hyperplasia of the adrenal glands, thereby increasing cortisol secretion. Cortisol's primary function is that of a glucocorticoid, but in excess, cortisol can act as a mineralocorticoid. Ultimately, this can cause hypertension and hypokalemia due to the renin-angiotensin-aldosterone system, or the RAS. The RAS regulates serum sodium levels and arterial blood pressure and can ultimately lead to hypokalemia. This process then leads to symptoms of formation of hypercortisolism. Clinical manifestations: MK presents to her PCP. The assessment shows moderate obesity, a round and full face, and significant facial hair growth. Her skin is thin and hyperpigmented with bruising present on her arms and hands. Her mucosal membranes show localized areas of hyperpigmentation as well. There are fat deposits in the dorsocervical region of her neck and upper back. Her abdomen is protuberant and rounded with stretch marks or striae, and bruising is present. She has some small, seemingly benign lumps in her right breast, and a mammogram is pending for her. Her upper and lower extremities are hyperpigmented. Muscle atrophy is present in all extremities, and the strength is scored a 3 out of 5 throughout. She also presents with hypertension, and her blood pressure reads 185/105. The patient's lab results reveal a sodium level of 145, which is borderline high, but a potassium level of 3.1, which is definitely low. This hypokalemia is due in part to the excess cortisol secretion, which oversaturates the receptors and causes increased reabsorption of sodium and increased urinary excretion of potassium, which results in hypokalemia. Cortisol inhibits the action of 11 beta-hydroxysteroid dehydrogenase type 2, which allows for the conversion of cortisol into cortisone. Because of this inhibition, cortisol circulates in excess and causes an increase in potassium excretion. The blood pH level also indicates alkalosis, which causes potassium excretion via the renal tubules, further worsening the hypokalemia. The patient's chloride level is 109, which indicates hyperchloremia. This can be due to excess mineralocorticoids or cortisol and causes increased sodium reabsorption, which ultimately leads to increased chloride levels. This can be contributed to the patient's excessive thirst and muscle atrophy and weakness. ACTH and cortisol levels are increased, indicative of Cushing syndrome. The patient's fasting glucose level is increased, likely due to the glucocorticoid nature of cortisol. The excessive amount of cortisol can contribute to glucose intolerance due to insulin resistance, enhanced gluconeogenesis, and increased glycogen storage in the liver. This can also contribute to the patient's increased thirst and appetite, mimicking signs of diabetes. The testosterone levels are increased, which is indicative of increased androgen excretion, which often occurs in females with Cushing syndrome. Increased cortisol levels cause hypogonadism, and overcompensation then occurs, leading to increased androgen levels. This explains the increased growth of facial hair and the deepened voice this patient is experiencing, as well as the menstrual irregularities. Studies also show that increased testosterone levels in females can cause depression and mood irregularities. Cortisol can cause a promotion of fat storage, altered fat distribution, and fat cell metabolism, and it can cause an alteration of muscle fibers, which can further contribute to altered fat metabolism and weight gain. Hypertension can result from Cushing syndrome due to high cortisol levels. Due to the cortisol's ability to retain sodium, the vascular nature of the RAS, and its ability to raise blood pressure and peripheral resistance. Excessive cortisol breaks down collagen and other proteins in the skin and the connective tissues. Cortisol decreases the amount of messenger RNA for collagen, which leads to lower collagen levels present. Cortisol also affects the maturation of collagen through proline and lysine, which renders collagen unstable and ineffective. This results in thin and fragile skin, the characteristic purple stretch marks or striae, and impaired wound healing. The role of the advanced practice nurse regarding caring for patients with Cushing syndrome include monitoring of physical and psychological symptoms. Also, fluid overload, high blood pressure, and high blood glucose management are necessary and will help manage comorbidities associated with this illness. Protection of injury and preventing skin breakdown is paramount in these patients as they have impaired wound healing and bone density loss over time. Dietary recommendations for patients with Cushing syndrome may include a diet low in sodium and high in potassium, calcium, and protein. Encouraging green leafy vegetables and foods high in calcium like dairy products, seeds, legumes, citrus fruits, and fortified cereals and breads may be beneficial for these patients, as well as foods high in vitamin D like eggs, fish, cheese, yogurt, and mushrooms. Dietary supplements may also be appropriate if adequate nutritional intake is not achieved through dietary needs. Some medications used in Cushing syndrome include antihypertensives and diuretics, specifically spironolactone because it is potassium sparing. Education regarding the disease and its progression will be helpful to the patient as it can lower anxiety and depression due to uncertainty. Depression related to testosterone levels should be evaluated and treated if appropriate and indicated. Self-care can help manage psychological symptoms as well as physical symptoms and should be encouraged to maintain mobility and prevent muscle atrophy and weakness. Collaborative care is pertinent for patients with Cushing disease as many comorbidities may arise requiring multiple providers' interventions. Endocrinologists, cardiologists, diabetes management, educators, physical therapists, surgeons if surgical intervention of adrenal glands is needed, primary care providers, and dietitians all play a role in managing Cushing disease. The case questions that I chose came from the case study. Of the vital signs listed above, which of them has to be of most concern to the patient's PCP? The vital sign that is most concerning is the critically high blood pressure. 185/105 is extremely high and could eventually cause hypertensive crisis if it further elevates. Stroke, heart attacks, heart failure, or kidney or ocular damage may occur if this hypertension persists and goes untreated. Identify 8 abnormal lab test results represented in the case study. 8 abnormal lab results from this case study include the potassium of 3.1, the chloride of 109, the fasting glucose of 170, the ACTH level of 290, the cortisol level of 73, the urine cortisol level collected over 24 hours of 190, the pH of 7.46, and the testosterone of 160. Do the laboratory results suggest that the hypercortisolism in MK is ACTH dependent or ACTH independent? The laboratory results suggest that the hypercortisolism in MK is ACTH dependent, which is evidenced by the extremely high levels of ACTH contributing to the high levels of free cortisol. And these are my references. Thank you for listening.